Thank you. As may have become apparent by now, I have a lot of interest in this area, but I wanted to specifically focus on patient-facing intervention. And this is new. It hasn't been published yet, so I'm excited about it. In terms of disclosures, my affiliations have been mentioned. The particular funding for this study came out from the CDC. I don't have conflicts of interest to report, and although I'm a VA employee, again, my views do not represent that of the VA. I want to thank the many people who contributed to this project before I start to describe it. The bolded names in particular on the colleague side are those people who were co-investigators on this project, but I also want to give credit to Aaron Bohnert and Steve Shermack, who did clinical supervision for this project, which gave me some insights into, their feedback gave me insights into what was going on with the intervention that I think influenced my interpretation of results. I also want to acknowledge Laura Thomas, who was a major contributor to this project in many ways over the years, and Maureen Walton, who really co-ran the project for me for a period where I was out because I gave birth. Hard to run a project from the hospital. So this is a behavioral intervention. As I mentioned, it was CDC funded, and it was specifically one of the small projects that are part of the CDC Injury Center here. The objective of my talk is to describe this pilot randomized controlled trial of a brief intervention. I'm calling it a pilot. Really, it was somewhere between a full-scale randomized controlled trial for a brief intervention and a feasibility pilot. I'll describe that a little bit more later, but I say that like a pilot, we learned a lot as we went along, but we also did find some intervention effects on behavioral outcomes, which we didn't anticipate given that it wasn't powered to do so. So I think I have the benefit of going later in the afternoon that I can skip a lot of the background on why we care about overdose, certainly, but I wanted to give a little rationale for the methods of this particular project. So we focused on the emergency department. We specifically intervened with patients while they were waiting for care there. So the reasons why the emergency department, in national studies, about a third of patients in the emergency department either get an opioid while they're there, often intravenously, or they leave with a prescription for an opioid. We also know that non-medical use of opioids is common among emergency department patients, and it's also the setting of acute treatment for overdose. So our particular study, we did not focus on patients who were there for an overdose, but the idea was that this type of intervention could build on that type of treatment as what's often in the emergency medicine literature called a teachable moment, someone who's just had a crisis related to some behavioral things that are not going well for them and being able to build upon that to encourage behavior change. In terms of why we chose a behavioral intervention specifically, our group had experience with a number of behavioral interventions related to substance use and specifically using a motivational interview style. And we've had effective interventions that have done this in reducing substance use and risky substance use in particular. I will say that from when we started this project to now, the idea of brief interventions for substance use has become somewhat more controversial in light of some large null trials that did not find effects, particularly for drug use. There's probably more evidence on the alcohol use side, although there's been some null trials there as well. However, that hadn't happened when we decided that this was the route to go. We also specifically wanted to try an approach that was not naloxone focused, and the next talk will cover that in much greater detail. But we knew that there were other studies already going on in that area, and we thought that if we could find an effect isolated with this, it would be interesting to see how it then combined later with naloxone those people who were indicated as being appropriate for it. And then another benefit of these brief interventions that are behavioral is that they're potentially low cost. And while there have been some challenges to dissemination of the prior interventions that have been found for alcohol, there are some EDs that have embraced this type of intervention, have staffed to be able to provide it either through doing training with existing staff or through hiring on master's level therapists. So there's potentially, at least in some settings, already someone in place who could deliver this type of intervention. This specific study was carried out at the University of Michigan Emergency Department. I don't think I have a pointer, but we're somewhere towards the middle of the picture currently, and the emergency department's in the foreground there. And it isn't all just college students, but I'll get to that more later. The protocol of the study, I'm going to go through this more chronologically of how the study proceeds rather than in a typical paper background methods, but so it'll be a little bit jumping around. But the research staff approached patients once they had been roomed, so meaning they had been brought into a private room, so there was privacy for all of the research protocols, but that they were still waiting for care at that point because oftentimes these emergency department visits are several hours long. We had them do a screen that was done by a computer tablet, so you can see our demonstration picture there. That was with staff, not with an actual participant. We kept the screen very brief because we wanted to be able to screen lots of people quickly. So it was no more than about 20 questions that only took 5 or 10 minutes to complete. And they also did an informed consent specifically to do that screen. And when people completed it, they were given the choice of items we'd gotten from a dollar store, actually, but geared towards things that could help entertain you while you're waiting for care. So things like puzzles. Those who were eligible based on the screen were recruited and did a second consent to participate in the baseline survey. And then at the completion of the baseline survey, they were randomized to either the intervention or an enhanced usual care condition. So during the assessment and all those interactions leading up to that, they both individuals were blind to assignment. In terms of eligibility criteria, our main criteria for this study was that they reported past 3-month prescription opioid misuse, and we measured that with some items from the current opioid misuse measure. The real measure is considerably longer, and we had to reduce down to make it appropriate for the emergency department setting. We took out some items that were more around general psychological distress and general problems that were not as specific to prescription opioid use behaviors that I'll show them later. We also focused on people between the ages of 18 and 60. As has been shown a couple times, that's really, at least with the data we have, that's where the burden of overdose is occurring. They had to be able to provide informed consent, which was really driven more by the exclusion criteria that are at the bottom there in terms of how we determined people who couldn't provide informed consent. They had to be English speaking because they needed to be able to interact with the therapist in the study. And we oversampled individuals with a prior overdose. And we use a very broad definition of overdose because we found, particularly actually when alcohol is involved, people don't necessarily identify with the term overdose. This is really sensitive, but I just want to be clear from the first time I'm mentioning it that our term overdose, it was a question about have you had more than your more drugs, alcohol, or medications than your body could handle. This could be called an overdose, poisoning, and gave some other examples like that. So we used the term, but it was considerably broader. I broke up the flow chart a little bit here for the study to make it readable, but you can see that we approached a fair number of people. About 16% refused to do the screen. Of those who completed the screen, about 10% are eligible. And so that's not only 10% who had recent past 3-month prescription opioid non-medical use, because that's more like a quarter of the people who we screen in the emergency department. That was including the criteria in order to oversample people who had had a prior overdose. And then of people who were eligible, about 85% went on to participate in the full study based on agreeing to do it and not having any of the exclusion criteria that we didn't find out about until the screening. I wanted to take a minute and talk about what the intervention itself looked like. So patients at the end of the baseline were where we were able to collect more information on outcome measures and things like that, were randomized to either the intervention or enhanced usual care only. And the intervention was a brief motivational enhancement intervention, so it included elements of motivational interviewing, the style of which is meant to be non-judgmental and empathetic, and to focus on increasing self-efficacy. Although our main outcome of interest was opioid overdose risk behaviors, the intervention also included content on your response when you see someone else overdose, and also on doing outreach to friends who are at risk. And we had hoped that perhaps those would be additional avenues of the intervention. We weren't really powered to look at those specifically, but one thing I think we did find, at least anecdotally from how the sessions went, was that taking some of the focus of the conversation off of you and your behavior helped engage people, and it helped reduce some of made people more open to recognizing it as a problem that they felt needed to be addressed. The intervention was delivered by master's level therapists. Still, while they were in the ED, there were maybe 7 cases that people left the ED, and we followed up with them afterwards. But by and large, in the ED, we had a computer aid, and what that was essentially an abbreviated version. I'll show some pictures, but an abbreviated version of the manual. So it was meant to help keep the therapist reminded of where they were in proceeding through the intervention. And it also included some visual aids and slides meant to be props so that it could be turned around when it would be helpful for the interaction with the participant. But in general, we definitely trained on trying to make it not interrupt the flow of the session and be a tool, but not be the focus of things. The enhanced usual care were a set of pamphlets on just basic psychoeducation around overdose prevention, and then on resources specific to the local community. And both conditions got those, and it was delivered by the same intervention regardless of condition. So in the intervention group, they got those at the very end of the session. The framework of the intervention based on motivational interviewing was Explore, Guide, Choose. So again, the structure was meant to increase self-efficacy and give participants a sense that they're making choices as they go through the intervention content. And it was also designed to allow for a lot of tailoring. So you can see the Explore section, there's quite a bit of open-ended questions that the therapist would ask to elicit that information in order to then use it to tailor the rest of the conversation. This is an example of the therapist guide that was computerized. And as we went on through the trial, the amount of text on the screen reduced down, but we started a little bit more in case someone got really lost and wasn't sure where they were, to have more information. But you can see the top had a reminder of what the purpose is of the overall section, and then also some therapist strategies from the motivational interviewing literature that would be relevant to that particular section, and then a reminder of the steps involved. And this specific part obviously came around what to do when you witness an overdose. This is an example from that same section on what would be a visual aid that could be used to help that discussion around responding to witnessed overdoses. And then this third screen is the last example I'll show from the computer guide, but this was specifically for prompts. So this screen wasn't necessarily meant to be turned around and showed to the participant unless it was found to be helpful, but this was essentially a checklist of, so the therapist would start with an open-ended question about what are your concerns. And if the person was like, oh yeah, it's totally that I'm worried about someone I care about dying, they could easily just click on that, and actually, because this was computerized, all that data was saved. But if someone was like, I don't know, I can't think of anything, they were able then to use it to help prompt them for answers if it was necessary. So we haven't looked at the data we collected from this at all, but it will be interesting to see what are the patterns of what people felt were their biggest concerns and goals and interests, and that'll hopefully help with improving the intervention for the next iteration. In terms of the sample, so I mentioned it was somewhere between a feasibility trial and a full-scale randomized trial. I'd say most full-scale trials for these types of brief interventions are typically around 500 participants or more. We had 204, but again, that's compared to some behavioral interventions. That's a fair number of people. So really in between. We were fortunate enough through the hard work of our follow-up staff to have an 87% follow-up rate at 6 months, which was our one follow-up assessment. As I mentioned, they're not all college students, so the mean age was 37 in the sample. And while Ann Arbor's not an incredibly diverse town, we had some non-white participants in the study. In terms of characterizing the study participants in their opioid use and their pain, we meant for this to be, because we were concerned about the potential for public health impact of the intervention, we kept it broad. So this wasn't meant to just be patients where their opioid use was really related to pain, nor was it meant to be people who were using purely for recreational reasons. And as a result, we got a mix of both. And that's where the tailoring of the intervention really comes in, so that you can change the conversation depending on what someone tells you about their use and about their pain. So by design, I mentioned we oversampled people with some sort of serious drug event or something that you might broadly call an overdose. And that was about 75% of people. About half had chronic pain. About 70% have been prescribed opiates. And a fair number of people would have been considered at high risk for problematic opioid use based on the assist. This I'm going to pick back up with the flow chart, and I'll go through this really briefly. It's a little bit complicated, but we showed, because of that oversampling of people with a prior overdose, we showed we were making a point to report the randomization by people with a prior overdose or not, since that's obviously going to be pretty related to their overdose risk and their overdose risk behaviors in the future. And we got good balance in terms of that for randomization and for other characteristics. I don't include all the details here. We did have some differential follow-up, actually, which we didn't expect, in that people who had had a prior overdose and who were randomized to the enhanced usual care only condition had lower follow-up rates than the other group, which is something I think in a larger trial we would hope to address better. And the other thing I wanted to mention is that we were able to follow 5 out of the 6 people who were considered intent to treat, meaning that they didn't get the full intervention that they were randomized to. So I would consider it a fairly accurate intent to treat analysis. The analysis strategy was generally through regression models, and what the main ones I'll show, we used Poisson regression because it better accounted for the count type distribution of the outcomes. But the main thing is that our primary variable of interest that I'm going to show is a group indicator that indicated people were in the intervention versus the control. And part of why we went with a regression rather than a more descriptive type of analysis is because we wanted to adjust for baseline level of the outcome. So in terms of the outcomes, and again, this is staff demonstrating what the intervention might look like. Our primary outcome was overdose risk behavior. We did look at overdose-related knowledge and behavioral intentions, and I'm not going to go into that in too much detail, and actually we didn't find as much there for reasons that potentially are explained by behavior change theory. So I'll focus mostly on overdose risk behaviors. An unfortunate thing is that there was not a good existing scale because this area of research was relatively new. There was not an existing scale on assessing this. Philip and I faced the same problem at the same time, as did Caleb Banna-Green. And so we worked together on coming up with a set of items and tailored some because we had slightly different populations that we were recruiting in our studies. In terms of the analysis, we found that the intervention, so looking at the first data row there, the intervention did result in reduced overdose risk behaviors at 6-month follow-up compared to the enhanced usual care only. In terms of actual change, that was about a 40% reduction and risk behavior compared to 15%. A secondary outcome was to look at the non-medical opioid use. So I mentioned this was measured with the COM, and here are the 8 items we used for screening in, but we also looked at them as an outcome at 6 months. And again, we found that the intervention group had lower levels of opioid misuse or non-medical opioid use at 6 months than the enhanced usual care. And this percent decrease was about 50% in the intervention compared to about 40% in enhanced usual care. So some conclusions of the study, we found that obviously we felt that the intervention was fairly feasible and it was highly acceptable to patients. As I mentioned, the focus away from exclusively on their own behavior went over well, and my clinical supervisors told me that they actually felt like there were fewer issues of patients being resistant to the intervention than there has been in some of our expert studies that are more focused on alcohol and drug use level. And we did have positive findings for self-reported behavioral outcomes. Some limitations of the study, as I mentioned a couple times here, it was not designed to be a definitive trial, and specifically we weren't able to look at clinical outcomes. So it'd be very important to look at actual overdose and future emergency department visits in a next step. The particular outcomes we're interested in, like overdose risk behaviors and level of non-medical opioid use, can't be validated through a urine drug screen, but that unfortunately meant that we were reliant on self-report data. And as I mentioned, these types of brief interventions have been disseminated some, but many emergency departments feel like they just don't have the staffing to take this on. So that's a challenge. We had initially, in terms of things we learned along the way, we had initially proposed to do what's called snowball recruitment or chain referral sampling, which can be useful for uncovering some harder to reach populations, figuring that people who have risky opioid use probably know other people who have risky opioid use. And this has worked really well in a lot of other substance abuse research, but it did not work well for us here. It may be that once people leave the emergency department, they don't necessarily want to continually have contact with people they associate with that visit. There were challenges in assessing some of, I won't go into too much detail, but I showed that list of risk behaviors. There were some others we would have liked to assess, like what people's total opiate dosage were. They were just really hard to assess in a self-report way. We did find that, so I mentioned the controversy around whether these motivational interviewing style interventions work, and we did feel like that there is potential for particularly a harm reduction message rather than purely a use, worrying about the level of use with that intervention style. In terms of next steps, we have some ongoing trials to study interventions that I would consider offspring of this intervention. One is expanded because it's happening during residential addictions treatment, so we have a little bit more time with people. It's 3 sessions, and it integrates information on HIV risk behavior. And then another that we're just starting is a VA study to do a full-size trial of a similar interventions, but specifically for patients who are getting higher dose opioid therapy for chronic pain, and it's going to be delivered by primary care mental health integration clinicians, since VA has those and are required to have them at every VA primary care. Other next steps, I've mentioned that obviously we have an interest in doing a full-scale trial so we can measure health outcomes. I mentioned some of the barriers around staffing, and I think using mHealth interventions are one way to increase the dissemination potential. And I'm also interested in going back to the idea of combining with naloxone dispensing. I think that is it.
I had a couple of questions. Some are simple. So how long was the intervention? How many interventionists did you have, and did you see much difference between those two? And then if I can follow up that with one other question.
Sure. It was about half an hour on average. We had 2 interventionists, which isn't a whole lot to look at therapist-specific effects. And I don't think we've looked at it at all yet, but that's something to too.
And then, did you find any difference in terms of sort of responsiveness to the word overdose and the concept of overdose among different participants in the study?
In terms of a negative reaction, I don't feel like we did much. I think some of it is the protocol where they had self-reported, in many cases had self-reported that they had it during the baseline assessment. So the people who felt that they had it had already told us, already been kind of primed by that question, and primed by that question using a very broad definition. Whereas then when it comes back up in the intervention session, it's not, we weren't able to integrate the data they gave us before. So it's not like, unfortunately, it'd be ideal if you could say, oh, in the baseline assessment, you mentioned that you had an overdose. Can you tell me more about that experience? We would, instead it was, have you had any experiences like this? And so it wasn't, I know that can be a problem, but it wasn't something we had a whole lot of problem with.